I still think the biggest issue that patients have and the wants that they desire is just more time with the physician, more personal contact with the physician. And we know people will pay for it. My view and my thesis on AI is that it augments physicians' ability to take care of patients, and it should increase like your efficiency and your productivity, not so much replace it.
Humans are getting so smart and technology is getting so smart that everything's moving so fast that I feel like we skipped the telehealth phase. Like the telehealth phase was just like 1 or 2 years in COVID. We didn't perfect that. And then we just all of a sudden was like, oh, okay, forget it. Let's just use robots.
Healthcare is like the one industry where we just complain, and nothing really gets done. I think we've seen like a lot of incremental changes, but never in our lifetime will we see like a socialized healthcare system. The closest thing America has to a socialized healthcare system is the VA. Yeah, you're asking great questions. You really did your research.
My guest today is not only a practicing physician, but also a healthcare systems engineer and the visionary founder of Healthcare Huddle. With over 30,000 healthcare professionals tuning into his newsletter, he has built a trusted platform that simplifies the complexities of medicine and healthcare innovation. From his work in the hospital to his insightful writing, he's bridging the gap between medicine, business, and technology. Dr. Jared Dashevsky, thank you so much for joining me.
Thank you for having me. And I want to steal that little intro for myself. It was very well said.
More than welcome to. I'll give it to you for half price.
Okay, good.
So I want to start by something that I read. I thought it was interesting. I want to go all the way back. Let me see if you remember this, to your medical school interview. I don't know if it was the first interview, but it was one of the interviews when you were asked the question about problems in American healthcare. And it was something maybe that you weren't so familiar with. I read that, you went in there and they hit you with that question. And I think you like maybe pardoned yourself and stepped away. Talk to me about that moment and how that shaped who you are today.
Yeah, wow, you dug deep. But yeah, I mean, you get hit with these questions in medical school interviews. And I was naive at the time. I kind of thought US healthcare was, what problems? Something wrong with it? I mean, listen, I was very fortunate growing up that I had access to healthcare, and I didn't really have anything wrong with me. Like I didn't have to wait for healthcare, and so I was very naive and ignorant to what goes on outside of my bubble growing up. So when the interviewers asked that question, I don't know if I said what my response was, but I don't know what I responded. Maybe I said what problems, I don't know, but I definitely didn't look too good with my answer. I'll tell you that.
What would be your answer today? I don't want to take you back to that moment, but what would be your answer today of what is the American healthcare problem?
I think the biggest problem besides like inequities is number one, but I think just the inefficiencies have just had so many ripple effects throughout healthcare that they've just caused so many issues, leading into inequities for sure, but also with like provider burnout, patient frustration, costs. You name it, it all ties back. Most things tie back to inefficiencies, but inefficiencies in healthcare is just a whole nother story.
You know what? Innovation is obviously something that's big. AI, all this stuff is big in our generation. Do you think that might cause more of a confusion and like a hurdle in healthcare? I don't know if that makes sense. It's great that innovation is coming, but I feel like there's so many like walls being put on, and just like, it takes so long for healthcare to catch up to things. Like, yeah, you can come up with an app today and everyone would turn it down. And in 20 years, they're going to be like, this is the greatest thing that's ever invented. It's like, how do you think innovation is going to be helpful in our generation, not the next? Because I feel like in the next, they'll see the impacts of it, but in ours.
Yeah, no, that's a great question. I think they say like healthcare lags 10 years behind every other industry in regards to technology.
Yeah.
Listen, I had to fax a letter yesterday. Who's still faxing? So we still haven't really solved. So in regards, like faxing is actually a good example. So right now, like we fax letters, insurance is like, you want prior auth, fax the letter to us. Doximity, which is like the physician social media app, they have a fax feature where you don't necessarily need to like scan something to like a printer or a fax machine. You could just like take a picture and fax that way, and you could receive fax. And I think like that's like a small step in innovating away from fax machines. It just makes it a little bit easier, but we're still stuck in the fax machine era. Yeah, I was gonna say in regards to AI to me, or the vibe I'm getting is that it's a little bit different, just because especially with generative AI, you yourself can like see the impact. Like you could use ChatGPT, Perplexity, Quad, and you could see like what the potential is like just by interacting with it. And I think the fact that it's like democratized, that type of technology, may actually help healthcare like adopt it more quickly. I think the biggest barriers will be like security stuff. Like, is this safe for patients? Who is responsible at the end of the day for any medical errors that come about it? I think there's a lot of legal stuff that may slow implementation.
Do you think? Well, I think the answer to this is yes. But how early do you think this will be implemented? Where medical schools need to start changing the way they teach medicine, because Grok, I think, is the AI for X. I believe that's the name of it. Yeah. So Grok said, like, Elon posted something where he said, like, oh, upload a picture of your X-ray or EKG, and it'll interpret it for you. Well,
Yeah.
it's like now, like, you're learning all this stuff, but like AI could just tell you the results of the X-ray. I don't even need to think about it. How soon do you think medical schools will catch up to this?
I think the best medical schools should be talking about AI like now. Like there should be some sort of discussion about AI in the curriculum. I know in residency, so there's this platform called Open Evidence, which is essentially a large language model that's just trained on like high quality journal publications. And you could ask Open Evidence any research question, and it will output a response with like citations and references that you can like fact check. And this is being used within my hospital, my program. Not like it's not like an announcement thing, but like you'll see like someone has a question, they'll discuss between physician and physician, and then like, oh, let's go to Open Evidence, see what the evidence shows really quickly. And I think we need to learn, and medical schools need to start teaching how AI can help and augment your abilities as a physician, not replace. I think every physician should be able to practice without AI, right? Because if the electricity went out tomorrow and someone comes to you with chest pain and all you have is an EKG, you need to be sure you could tell if there's like T wave inversions, ST elevations. Like you got to make sure someone's not having a heart attack. My view and my thesis on AI is that it augments physicians' ability to take care of patients, and it should increase like your efficiency and your productivity, not so much replace it. Again, I think I wrote about these like medical research platforms back in July or August, where I talk about Open Evidence. I talk about Doximity, the little platform, and what it comes down to is these platforms like chomping away like 30 minutes, an hour of time you would have otherwise spent researching a clinical question, like into seconds, right? Like before you would
Yeah.
open up a textbook or go to PubMed and like do this whole lit history. But now you can just like ask generative AI a question. It will show you the resources or the references, and you could fact check yourself.
Yeah. Do you think that the older generation is just like sitting there and just waiting for them to be like, I told you AI is not going to work. I told you this is not it. Be- And because I feel like that's how it was when the news about Forward came out. And like, man, I saw people posting on LinkedIn that haven't posted in years just to say, like, we told you it wasn't going to work. They had like $600 million and they still couldn't do it, blah, 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 blah.
Yeah.
So I know you wrote about it. Tell me about your thoughts about Forward. Why do you think, the downfall of it was, even if it wasn't a downfall, we don't even know there's so many things that go into it. That's like, we just see the news of like, oh, you go on the website and it says we're not here anymore. And you just think like, oh, failure. It might not have been that. What's your opinion on that? What's your take?
Yeah, so I think I used the word failure. I don't like to use the word failure because um just
Yeah.
wasn't successful. And I don't think
Yeah.
saying not successful equates to failure, but I think they raised a lot of money, right? 600 million. I think they're like their direct primary care model. I think that was a great model, right? Like you cut out insurance, you're giving like high high quality, I want to say, care to patients who can afford to pay whatever price they charge. Um, they had established relationships with physicians. They had 24/7 access to the physicians, like all the things like we would want in an ideal world for just your regular primary care provider. I think what went wrong was these AI or these care pods, which by all means like wanted to like replace the touch points of healthcare where like it's a provider, it's a nurse, it's a physician taking care of you. And I think even there was a quote by the founder saying like he really wants to replace all the like actions nurses and physicians can do with just this like AI. 100 years from now, maybe yes. I don't think we're ready for that yet. I still think the biggest issue that patients have and the wants that they desire is just more time with the physician, more personal contact with the physician. And we know people will pay for it. Um, Again, like, because people buy into these direct primary care models, like concierge medicine is taking off. Like, people will pay extra. Of course, this can lead to inequities for people who don't have the money to pay for extra time. But at the end of the day, people just want more time with the physician. They want to feel heard, listened to. Replacing physicians right now with AI or even like talks about it, I just don't think the market is ready for that. And I think that's why they failed. And plus, you're putting care pods in malls, in like high income places. It's still foreign. It's not like a regular thing yet. Um, so it may not survive. Uh, and I think that's what happened. And they ran out of cash.
You know
And we
what?
can go into what happened. Yeah.
No, go ahead. Go ahead.
Yeah, so I was gonna say I posted about it on LinkedIn or someone like posted about my article. And they were talking about like an Israeli company that has these like makeshift pods. So they're like AI driven, but you could basically walk into like a phone booth of sorts, and you just sit down, click play, like a provider pops up, and like you can just get like quick care there. Kind of like a kiosk, I guess, for physicians, which seems like a smart model. I feel like that should be the first step in regards to like your iteration process. Is like start with a human model first, and then you could to figure out what can be replaced.
Yeah, yeah. I don't think we're ready for Tesla robots to be my
Oh, no.
physician. Yeah, it's crazy because COVID brought on telemedicine, telehealth, and I feel like people weren't even ready for the patients weren't even ready for that part of it. They're like, man, I don't get to see my physician in person. Like you're still talking to your physician, but like you wouldn't see them in person. They were holding off so much on getting that telehealth service, and I feel like we're in a stage where like humans are getting so smart and technology is getting so smart that everything's moving so fast that I feel like we skipped the telehealth phase. Like the telehealth phase was just like 1 or 2 years in COVID. We didn't perfect that. And then we just all of a sudden was like, oh, okay, forget it. Let's just use robots. And it's like, man, we didn't perfect this part. Let's take it one step at a time. Healthcare, as we spoke, already takes so long for things to be implemented. We didn't even get to implement telehealth perfectly. And I feel like we skipped steps. Do you agree with that?
No, that's actually a really good take. That's really good insight. And I would have to agree with you on that. That telehealth is still brand new. Like we still don't even
Yeah.
have like Congress is still set to decide of whether to extend telehealth flexibilities to allow like all Medicare patients to get reimbursed for telehealth. That you don't have to be like there's no restrictions on it. Like we still don't have policy in place to
Yeah.
allow telehealth to flourish. So I kind of agree with that. That we haven't perfected the telehealth, so we actually really don't know like all the potential it has. Right, like right now, people are building like virtual primary care practices where you're a primary care provider and you're just practicing all virtual, which can be done like primary, you could just have someone order labs. Maybe you need to see them in person once and you can rent office space for that. But other than that, like if you're just doing checkups, someone comes in with like a sniffling nose, like you can treat that virtually. Um, so, you know, I'm, you should, we should move quickly in healthcare, but we don't want to break anything. And I think we should perfect the art of telehealth first, uh, and see how AI could even be incorporated in there versus trying to
Exactly.
replace everything with AI. Again, I don't think AI is here to AI shouldn't be here to replace physicians. It can replace like processes to improve efficiency, but yeah, it should be here to augment um, our
Exactly.
abilities. Yeah,
Hey, maybe that's next healthcare huddle article right there, expanding
no,
on
that's really good.
telehealth.
Don't plug this
um,
podcast.
Medicare is cutting the payments of physicians into 2025 by 2.8%. And I think you touched on a little bit about concierge medicine. Where do you see the role of concierge medicine, direct patient care going in the future? Do you think I don't think there's ever going to be a time where majority of people are concierge versus taking Medicare and insurance because of just the population, unless like the whole American healthcare system changes, then that's maybe it will happen. But we don't see that foresee that happening in our lifetime. So where do you see the role of concierge medicine going? Because I see a lot of doctors that are just fed up with the insurances. They're like, man, I'm tired of the insurance telling me how to practice. I'm just going to open my own practice and practice how I was taught in medical school.
Yeah, I think Medicare is not doing physicians a favor by decreasing reimbursements despite inflation. It's just so backwards. And of course, there's talks about with the incoming administration to like do an overhaul of Medicare reimbursement and physician reimbursement. I'll believe it when I see it. Uh, Concierge medicine. How do I want to say? I'm all for primary care, direct care in general, and concierge medicine. I think it's a solution for the physician and the individual patient. It's not a solution for the system, right? Because as a concierge physician, a direct primary care physician, you inherently need to take your patient panel needs to be less, right? Because now you need to be like more in control of who you're seeing, how often you're seeing them. Um, and so, we already have a shortage of primary care physicians. So by decreasing patient panels, you know, where these other patients go, they go to whatever primary care provider that's not doing that. And like, it takes 3 months to get in to see them. Uh, so, I mean, there will be ripple effects, but for the individual physician who wants their autonomy, which is at the end of the day, what physicians want, this autonomy and to be paid for their expertise, these are great models, right? You tap into a population who can afford um, the fees. Direct primary care, maybe it's for people with high deductible plans or patients without insurance. Like I'm fine, I'm healthy, I'll pay 150 a month just to get into you. Um, and I think it's a sustainable model for sure. And I think we will definitely see more physicians graduate from residency and try to go into these types of practices. And we may even see like scalable DPC and concierge medicine practices. Um, there are already like big groups that do this, but like little by little, I think more people will. Listen, I'm interested in in pulmonology critical care. Critical care is hospital. So like, what's taking cash payments for your time in the ICU. But for pulmonology, for like bread and butter conditions like asthma or COPD, you can very well turn that into a direct model where you're an outpatient provider and you are charging patients X amount per month to just treat and manage their asthma, their COPD, like these bread and butter conditions that like we have like standardized guidelines for. Um, so, I mean, that's like my vision for my career. So I think these models are going to get more popular, especially as Medicare squeezes out reimbursement.
Do you think this is a big loaded question, so I don't think anyone has the answer to this, but do you think there will ever be a time where the healthcare system in America just changes for the better. Like, I feel like, man, our parents' generation, our generation, our grandparents' generation, it's all been such a fighting thing. And we're like, one of the greatest countries in the world, right? And we're out here struggling with the most important thing in the world. It's like, c- man, I know it's a loaded question, but I would love to take your intake on like, what do you think about that? Like, why do you
Yeah,
think
so
it's just not fixing?
yeah, I think there's many reasons. Just taking a step back, healthcare is like the one industry where we just complain, 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 and nothing really gets done. I think we've seen like a lot of incremental changes, but never in our lifetime will we see like a socialized healthcare system. The closest thing America has to a socialized healthcare system is the VA. Um, and even the VA hasn't been able to perfect it because a couple years ago, Congress passed a bill that allows veterans to like tap into private care if there's too long of a wait to get into specialty care within the VA system. So I like everything just goes back to private insurance. Um, there's this philosophy or theory called uh, Lindy's law or the Lindy effect, something like that. That basically says like the longer systems are in place, the harder it is to get rid of them. And I think that's just what we're seeing in the United States healthcare. Like going back to the private health insurance or employee sponsored health insurance is what 1940s, which just came about to incentivize employers to increase their workforce. Right, they get tax benefits by providing health insurance. And since then, in like a completely different period in wartime, like things have improved. I mean, sorry, it just has stuck around. Things haven't improved, it just stuck around. Um, and what is that? Almost 80 years, and like employer sponsored health insurance has just been more cemented, has just gotten more expensive. There needs to be an alternative. You have like value based care models, like risk based modeling coming out,
Man, that's
or
been
getting
talked
more.
about for so long. And the word
Exactly.
value-based care has been talked about for so long. And it's like, when I was in school, I was like, oh yeah, value-based care, the doctors don't get paid per head. Like it's about how healthy they are. And they're like, what are you talking about, man? Like, no, that's not, I'm like, wait, I've been hearing this for years. And it's like, it's, I don't know. Yeah.
Yeah, and when someone says value based care to me, my mind it literally like shuts off. I become Drew. I'm like, oh, whatever. And these models, like the ACO models, like they're not having the outcomes that we expect them to have. And I think at the end of the day, it's going to require a mix of like fee for service, direct primary care or direct care models, and risk based arrangements. Um, I think that's just what's going to end up happening. But I, you know, I think it's incumbent on like individuals to try to fix what they can. Like with Healthcare Huddle, I can make people aware of the inefficiencies I see, right? I'm on the front lines. I could like, there's like little problems that exist that other people aren't seeing. And maybe by me bringing or shedding those problems to or bring those to light or however you say it, like people can be like, oh, I'm going to investigate that problem and try to create a solution for it.
Earlier, you mentioned, we were talking about concierge medicine. Obviously, the shortage of primary care physicians. I'm not sure how in depth, about like the pharmacy profession. Obviously, I'm a pharmacist, and we're in a big transition phase of the role of a pharmacist, and how what role we play in healthcare. We're still fighting for provider status and being recognized as healthcare professionals, and so on and so forth. A lot of people right now think that pharmacists can play a big role in the concierge medicine world with the physicians, being that like the assistant provider, like for the physician, teaming up together to care for these patients. As a younger physician, I would love to know your intake on pharmacists and what role have you seen them play in your world, in your day to day basis, and what role do you see them playing in the future? Because I feel like there's so much backlash just going back and forth with like the AMA and the pharmacists and this and that. And I agree with some and don't with others also. Like the fact that, these pharmacists are fighting for like prescribing rights or being able to diagnose. I don't think that that's the path that pharmacists should go down. I think, I always say this analogy of like, there's a plane, right? There's a pilot and a co pilot. and we got to figure out who the pilot is. And in this case, in healthcare, it's the physician. Physician diagnoses, and the pharmacist can help manage that. But we did not. I'm a newer guy. Graduated like 2022. So I'm a newer pharmacist. So, and I didn't go to school to learn how to diagnose. I learned about medications and how they treat your body, and how we can treat the diseases, and that the physician diagnoses. So I feel like a lot of people are fighting for the wrong things, but I would love to hear from the physician perspective, a newer physician perspective, on your take on the future of pharmacist's role within your practice, and how you're communicating with them these days.
Yeah, I'm happy with that. But for some reason, I've been writing a lot about pharmacists. Um,
I think that's how you caught my attention. I've been following you for a while, and then you wrote about an article, a post that I want to talk about later, the discharge of
okay.
the pharmacist. We'll talk about that one.
Yeah, yeah.
But that was the one that caught me.
Yes, I think just in medical school, you're not really taught about the resources that support physicians, um, or patients, let alone. And I think what I'm realizing as I do my training, and I interact with the healthcare system and try to get patients care is, um, pharmacists play a huge role in medication management, transitions of care, especially, um, and they can offer so much support to improve patients' like well-being. I'm in New York City. Patients here are just incredibly sick. They have so many comorbidities, and it's similar to like any major city. And some patients are on dozens of medications. Oh my god, how can I How can I address polypharmacy? And for someone who listen, I know medications. I'm not an expert. Um, so I tap into the pharmacist. Hey, can you please help me like reconcile these medications and figure out, are there combo pills I can use? Um, is there one pill that can kill two birds with one stone? Right? Like, how can we reduce polypharmacy? Because as we know, especially in older adults, polypharmacy is like no bueno. Like, you can cause fault. Like, bad things can happen. So I've been tapping into pharmacists to help with medication management. Um, we have services where I'm at to, you know, I start patients on a new blood pressure regimen. Instead of me seeing that patient every week to titrate, the pharmacist does phone calls with them, checks in on their remote patient monitoring blood pressure kit, and can titrate the medications appropriately. Oh, blood pressure still not within goal. Let's increase olmesartan to, I don't know, 40 milligrams, or let's add nifedipine, something like that. And that saves me time. And, I trust pharmacists with when it comes to medications, and, they're aware of interactions, so forth. And, same thing with like diabetes medications. Pharmacists can totally help titrate insulin, you know, increase doses of Ozempic, Mounjaro, stuff like that. Um, I think once you realize it, like the support pharmacists can offer, I think it allows you to take better care of your patients.
Do you think that the average person or average doctor realizes that a pharmacist has a doctor of pharmacy degree, like a doctorate degree?
Uh, I definitely realize it. I would assume, yeah, I'd assume my colleagues know that you're doctors of pharmacy. Um,
I don't know, because doctor of pharmacy is fairly a new degree. It became like a thing, like in like that, where everywhere had to, all the pharmacy schools had to have it around the early 2000s. So it's not really that, like, that old. It's a lot. There's some pharmacists that still have a B Pharm and just a RPH, and they don't have a Pharm D. So it's. I feel like maybe the older physicians are not prone to realizing the education that we go through. Like we have residencies, we go through residencies, we have 4 years of programs that we go to, but I feel like pharmacy is just really misunderstood. And then the pharmacists that are the loudest now are like the older ones that are fed up with the system, that are maybe not helping it as much as they should be, because of the tone that they're using to try to push the profession.
yeah, that's it. That's interesting. I think it could be like the old school people who aren't aware, but listen, I write about them. I try to make people aware of the tools that pharmacists can offer. I mean, especially in the hospital, like ID pharmacists are amazing. Like, they really
Yeah.
help with antibiotic stewardship.
Yeah.
Um, like if it weren't for an ID pharmacist, like I'd be prescribing meropenem to every.
Oh, oh, you picked the perfect one too. You picked the perfect one. We spoke a little bit about, like you're interested in critical care. And that's the hospital setting, obviously. How do you see the role of hospitals evolving in the future? Because I don't really see hospitals being the center of the healthcare in the future. I would love to get your point of view on that.
Yeah, I mean, I think what we'll see um, is that the ability to provide not acute care, but like high quality, like subacute care in the outpatient setting, it's going to get more robust. Um,
Yeah.
and then, especially with like hospital at home programs,
Yeah.
basically, if
I was going to ask you about that.
yeah, so for hospital at home, like you you go to the emergency department, you have community acquired pneumonia or like a kidney stone or an asthma exacerbation, and it's not severe, it's manageable. This you could be admitted, but to home, and you'll be monitored by a physician and a nursing team in the comfort of your own home. Just because the condition you have is so common, there is bread and butter treatment for it, and by treating you in the home, one, probably better outcomes because less likely to get delirium. You're not boarding in the ED, but also it opens up beds in the hospital to allow the more high acuity. Um, so like we managing like community acquired pneumonia in the home, like we could really push stuff to the outpatient ambulatory setting. What I see happening though is that the patients who are admitted are are just going to get sicker and sicker. Like they're going to be like really high acuity because they can't be managed outpatient wise. Um, the biggest bottleneck will be resources. Like, do we have the resources and the technology available to treat like acute patients in the outpatient setting or at home? Like for hospital at home, we need remote patient monitoring. You need internet access. You need telehealth. You need um, nurses to see the patients. You need some sort of like courier to deliver medications. You need caregivers, right? Because one of the downsides of hospital at home is that someone needs to take care of you when there's no nurses there. So do you have family members? Uh, but I do envision everything's going to be pushed towards the outpatient ambulatory setting, and the patients who are now going to be admitted are the patients who uh, are very sick. And so, like, you may be treating ICU level, like critical care, may be like even more intense
Okay. All right. So
because like the regular floor is managing the sick patients.
you had mentioned in a post a while ago, like I think 4 years ago it was, said you said, now I want to be a doctor and an entrepreneur, not just treating patients, but treating populations and education peers. How has your I guess vision for yourself, for your future of what how you want to practice, what you want to do, how has that changed since I guess starting your residency career or since becoming an MD? How has that changed
Yeah,
over the
yeah.
years?
I think it's just like my desire to like be this like doctorpreneur and like wear two hats has like further been solidified. Like that's what I want to do. Um, someone once told me like as a doctor, you're getting paid to solve problems, and it's really changed my mindset about being a physician. Is like patients admitted to my team. It could be that the third patient that's admitted in like a 12-hour period. Like I'm swamped, but like I'm being paid to like solve a problem. Like what is wrong with this patient? And like it's really cool, right? You're using your clinical expertise to solve problems, and could save lives. The same thing with problems in healthcare, right? It's like with Healthcare Huddle, like I can identify problems and like figure out ways to solve them, or like at least provide some sort of uh, foundation for my audience to take off and solve. And Healthcare Huddle, the impetus was one that in medical school interview where I didn't know anything about healthcare, and I got a master's in engineering, and like all of a sudden I'm learning so much about healthcare, and I'm like, I think not enough physicians or providers are up to date on what's going on in the industry. And, you know, healthcare, yes, it affects patients, but also affects patients far from the bedside. Policy affects patients. Insurance affects patients. Drug pricing affects patients. And I'm like, we need to know this stuff, right? So that was the problem. The solution was Healthcare Huddle, like this media platform that, is helping educate health professionals on what's happening in the industry.
You got a master's in engineering. I feel like you were so ahead of your time. It was like the perfect degree to get. Um, how did that decision come about? Do you have family members that are in that field? Did a mentor of you direct you towards that? Because that's like the perfect combo of degrees you can get right now in our lifetime in our generation.
Yeah. So I went to Lehigh University, which is Bethlehem, Pennsylvania, and they offer like something called the Presidential Scholarship if you have like above a certain GPA, where you can get a master's for free. Um, so I was like, what's the rush? Like my medical training's gonna be long anyways. Like why not explore? So I was like exploring what degrees I can get. I studied psychology and medical in undergrad. So I'm like, do I want a master's in psychology? I don't know. What can I do with that? Do I want a master's in like physics? Am I going to radiology or no, probably not. And then there's this newish program called Healthcare Systems Engineering, which basically blends together industrial systems engineering concepts, methodology, and applies it to healthcare. And Lehigh is a huge engineering school. And my thought was, engineering will be the one degree I don't tap into. Like I already have I already have like bachelor's of science. Like what about engineering? And so I applied, I got in, and uh, it was it was such like a turning point in my like healthcare career because like I'm like seeing things for the first time in a different light. I'm now like learning how to apply like engineering concepts to solve problems in healthcare, and it was just so great. And then as soon as I finished, like I knew I was very process oriented. I see things very systematically. I problem solve systematically. And I'm like, this is what I want to do with my career. Throughout my training, I'm involved with like quality improvement projects. So it's like root cause analysis committees. So like I'm still bringing the concepts I learned to really apply to my current career.
I think in healthcare, so in the school I went to, there's a pharmacy school, dentistry school, and a medical school all on the same campus. So it's like there's a lot of like interprofessional networking opportunities with other students. And what I always saw was like I always figured there was two types of people that go to healthcare. There's the book smart, and then there's the quote unquote street smart, right? And you don't really see too many of the street smarts, right? People that usually go to healthcare book smart, because obviously the complexity of like the studies, how it's just the extensive amounts of nights of studying and tests, and you have tests every week and quiz every day and this and that. What role did your brother Brett play in your street smart business side of your brain? Because he's not in healthcare. How was that relationship? Because you guys did do healthcare huddle together.
Yeah, you're asking great questions. You really did your research. Yeah, Brett. So we started Healthcare Huddle together. He was a senior at Maryland at the time. Senior or junior? Senior, I think. Yeah. And he's a business guy. His whole idea was to, just be in the industry. But he is so creative, like truly has an eye for what looks good. So he's amazing with branding. He is, he's like a politician. He knows how to talk to people. He knows how to sell. Um, very confident in his abilities. And, I brought him on because my deficiency is I'm creative, but like design, I don't know anything about. I didn't go to school for business. So like business models, not really me. Um, didn't really know much about the media space, but Brett was very well versed in media. So I brought him on and he really like complemented the skills that I lacked. And I learned a lot from him. So like we grew Healthcare Huddle together and he like made Healthcare Huddle look like it had been around for years, even though like we were months old. because he just made the design look so like professional. Um, and then, he eventually started at Capital One and then ended up quitting once Healthcare Huddle got acquired by Workweek in like 2021, which was like a big moment. And then since then, he's just now in the media space. He's like working at Kickstarter, starting a whole like creator community here in New York City, which is very successful, and working on his own startup. But he definitely supplied the street smart skills, the skills that I really didn't learn in my science based programs, especially in the creative domain, and really helped get Healthcare Huddle to where it is today.
Yeah, I always say like, it takes more than one person to be able to succeed at something, and you always need that balance. So like you need to find out what you're good at, what you're not, and hire someone or bring in someone to do the things that you're not good at. And that's the only way you're going to succeed in anything.
No, for sure. And I think when it comes, I know this is ex- um, a podcast not about business, but uh, when you're choosing co-founders and you're choosing a team, yeah, you need people who complement the skills where you're deficient in. So that way you can learn from them, but also like you have someone who's confident in their own abilities. Not to go off topic, but this comes back to digital health companies who are creating, these healthcare startups without any physician on board or any
Ah,
clinician on board.
you just opened another hour of conversation, man.
So like, how are you going to create a digital health company that's all about asthma, but you have no expert telling you actually how to treat it? Um,
Ah,
so I think a lot of digital health companies that struggle right now are ones who don't have um, the physician founder or the physician like board member, right? Like everyone talks about the technical founder, the one who can
yeah.
code, but in digital health, you kind of need that medical founder.
Yeah, you just hit a nerve right now. Like when you said that, because I'm so passionate about that. I think I made a post on LinkedIn about it, how related to just pharmacy, but I get in healthcare also. Whenever I see like a pharmacy related company, whether it be like an EHR dedicated for just pharmacists to do concierge pharmacy or whatever it might be, and I first thing I do always, or even healthcare, I always go to that page where it says leadership, and I always scroll down to see the founder, the CEO. And when that just doesn't has an extra letter after their name, I'm like, man, like all due respect, like everyone's talented in their ways and so on. But I think if you're a healthcare company, you need to have at least a healthcare CEO. Let's say it's fine if it's not a founder, but at least a healthcare CEO to really understand it. And there's I don't want to say names, but there's pharmacies out there, big chain pharmacies that a lot of people complain about. And if you look at their CEOs, they're not pharmacists. And it's like, all right, well, pharmacists are complaining because maybe the leader just doesn't understand what's going on the floor. They've never trained as a pharmacist to understand a day-to-day job of a pharmacist. And maybe we should start by putting, instead of the vice president of the company being pharmacist, maybe the CEO needs to be the pharmacist so they can push down under that leadership. It's
Yeah, for sure. And there are pharmacists with MBAs, right?
yeah.
Like they're out there. You can find them.
Oh,
Same thing
bunch,
with
like bunch.
Yeah, same thing with like CEOs of health systems, right? It's like the CEOs who have clinical background and are also well versed in business. Like those are the best ones because they can um, better relate to their employees and they also understand the landscape better. Our At my hospital, like the president, he still does some shifts in the OR. He's an anesthesiologist, and every now and then, frequently, like I see him walking around the hospital, like saying hi to uh, fellow nurses and physicians, and like that's who I want. That's who I want leading health systems.
Yeah, yeah, and I think one thing I respect about Cleveland Clinic is I believe this is true that they only hire doctors as their CEOs. They don't
Oh,
hire
nice.
out. They only so all of their CEOs have always been doctors.
Right.
So I respect that from them because it makes a difference, right? How hard has it been for yourself to be yourself in your posts while being a resident? When I was a student and when I was like, doing residency a little bit, and it was hard. I feel like I was being judged by my like attendings or like
Mm.
people that maybe don't understand your world, of writing and just expressing your opinions. How hard is it to be yourself and fully be transparent on how you feel? Do you ever hold back because you're like, man, if I post this, maybe, attending might see it and he might think opposite and might be a little weird.
No, that's a good question. I think at first, early on, I was very timid and like anxious and nervous about posting my thoughts out there. At this point, I just put I'm at this point I'm very confident in my takes. Like I don't usually say stuff. I don't usually like quote unquote pull stuff out of my ass and like say it like usually what I say is thought out and I have an opinion on it and I've written about it and I have facts to back it up. Um, and at this point, if I have fellow peers and physicians come up to me and like compliment me like, "Oh, I love your post on forward health. Like, totally see where you're coming from. Oh, concierge health. Totally see where you're coming from." Um, maybe perhaps like the more controversial stuff. Uh, I'm definitely take time to like make sure I'm saying it right. For example, this past election, very contentious. I wrote an article on like what healthcare would look like. And I made sure like for this article, I'm going to be very objective in the first two sections, which is usually my like objective section. And then in the my Dashevsky dissection part, where like it's my own take, I'll be subjective, offer like some data with it, off like link previous posts I've written. Um, just to show where I stand. And I think that's perfectly okay. I totally realize there's going to be many people who don't agree with my takes, and I'm totally open to it. I think when I've written about like Roe v. Wade years ago, like I remember like someone responded and was like, "Jared, love your work. I'm just going to say like, I disagree with your take," and that's great. Like we should have discussions. To talk things out. So yeah, I first again very nervous. Now I just post.
You talked about your, DMs. How has your DMs on LinkedIn changed since the day you started? Because I remember I saw you, I read, or you were saying in another podcast where you had made a post about something. I don't remember exactly what you said it was, but someone from PillPack, like a higher up or whatever, messaged you and said, like, how do you think this is going to really help people? And then you said something and he gave you a whole paragraph of like whatever. How has your DMs of like influential people that are, higher tier, like making comments to your posts behind the scene, whether it be good or bad, agreeing behind the scenes because they can't agree with you in your comments because
Yeah,
of
yeah,
their stature. How has that changed over the years?
yeah. So like more and more people are reaching out and offering their opinions. I definitely get replies. Like when I wrote about continuous glucose monitoring companies. Like at first, I had a very strong take on them. Now, I've eased off. But like CEOs of all these digital health companies, like have reached out to me. They've sent me like free trials of their CGMs to use. Again, like with the PillPack founders, like sometimes when I write about drug pricing, like I get something's off with my take, and they'll be like transparent and like give me a new way to look at it. And I'm like, thank you for reaching out and like feeling that deficiency in my knowledge. Um, like execs have reached out about certain like business stuff I've written about. So like over the years, it's like now, what at least once a week, someone's DMing me, uh, sharing their take, offering their own analysis, asking to chat further. So it's cool. It's cool.
Have you when you started Healthcare Huddle, I don't, maybe this wasn't something you thought in back of your head, or this was an intention of like the reach you're gonna have, or like the health, the networking, the A tier networking you would have with the people you attract. How have you thought about like how you would use the platform selfishly, saying it in a good way, to kind of explore your future of like whether it be where you practice or how you advance. I don't know if that makes any sense. Like,
No, I kind of see what you're saying. Like, am I using Healthcare Huddle to like my advantage to like help like kickstart my career in medicine or something like
correct,
that?
correct, 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 correct.
Yeah, yeah. I'm definitely trying to connect with as many people as possible. As of now, like I'm interested in doing a fellowship in pulmonary critical care. After that, like I really do like the academic environment and teaching, but I don't want to live there. Right. It's like I do want I do need a foot in medicine and a foot in, you know, entrepreneurship land. In Healthcare Huddle, I plan to continue doing it. So maybe that's what I do. But I like consulting for digital health companies or like startups who like are trying to figure out or navigate this landscape. I like doing that. So like maybe I have a side gig in consulting. Um, Maybe I connect with someone in my audience who has that career and they could, advise me, stuff like that. So I'm definitely keeping track of who reaches out to me, who's in my community, seeing like what their career path has looked like and like reaching out to them, and be like, hey, I admire the path you had. I kind of want that.
Do you and your brother Brett ever he's like, man, listen, just go do your residency, finish it, and come back and let's just make this company that I've been thinking about for 10, 15 years. I know we can like do great things with it. I need your expertise as a physician. I got the business side. Let's get into it as a family and just make this Apple
Yeah.
or
Yeah.
whatever it is.
Yeah. Yes. Listen, like I trust him. And if he presented with like a truly revolutionary idea that needed my clinical expertise or like something in healthcare, I would definitely consider it. Even for being brothers, we're close in age, we're 3 years apart. Like we do work very well together. Um, so I would definitely consider it. It was very fun working with him, and I have a lot of trust in him, and he trusted me, and we know each other obviously very well. And uh, I think we could do it.
I'll be looking for that app or company, Dashevsky. I'll be looking for that name. That's going to be the name of it. I'm going to be looking for it. Um, we talked about it a little bit. Let's deep dive into it. You made a post about the dangerous things that we do in a hospital, and you named the things, and then you said the most dangerous thing is discharging a patient. Elaborate on that post that you made, because I think I made a comment about like, how like pharmacists can help in that whole transitions of care and how they can be helpful. But explain how the most dangerous thing is patient leaving the hospital.
Yeah. So I don't know who said it to me, but one attending was like, the most dangerous thing you can do right now is send this patient home. And I'm like, but they're fine. They're like, yeah, but you don't know what they're going to do in the home. We're discharging them on 3 new medications. Do they have cardiology follow up? Do they have pulmonology follow up? Right. They just had a COPD exacerbation and they also had a heart failure exacerbation. So like, this is like, yes, they're good now, but will they still be good? Um, and so I wrote this post because I think it's important to realize that like, when a patient's in the hospital, they're in such a controlled setting. All the meds are giving them. You know that they're taking them. You know what time they're taking them. You know when they're being fed. You know when they're pooping. You know how much urine they're making. Like everything is controlled, especially in the ICU setting. So when you send them out in the real world, it's up to them to take their medications. And if they have home health aides who are going to be there, like they can help out. If they're going to a subacute rehab center, they'll get help there. But you, as a physician, you just don't know, like, are they actually going to get all of that? And so discharging a patient is very risky, right? Especially if they come back. And so what I've been doing, or like part of the post was for me to talk about, I have this like checklist that I use to make sure I did everything on my part to ensure that this is going to be a safe discharge, that I've made the outpatient appointment follow-ups, that I've talked to social work to get home PT, to get a home health aide, that the family is aware, that the pharmacy did a medrec, or that the transition of care pharmacist helped me make sure that all of their medications have been approved by insurance. Because, for example, I had a patient with a pulmonary embolism, and they had to take either Xarelto or Eliquis. They both can cost a lot of money. So we were getting ready to discharge, and we sent Eliquis. The wife went to pick it up. Doc, this is hundreds of dollars. I'm like, what? And then so I'm like, God. So then I had to send Xarelto, and then we had to do the whole prior authorization process. I had to talk to Optum. A complete mess. So now, like, is there someone who can help? Pharmacists can help assist with like the whole medrec and discharge. But yeah, discharging a patient gives me a lot of anxiety.
Do you think not a lot of physicians spend enough time on the after visit, the AVS, the after visit summary, to like the medications, to like consolidate those medications properly? Do you think they don't spend enough time on that? Because man, whenever I look after a visit summary for a patient, I always find at least something missing or something wrong with it. Do you think physicians just are maybe expecting the pharmacist to pick it up and pick these things up, or what do you think that missing thing is, or you just don't experience that at all and you think they do a good job?
Yeah, so you're talking about ABS, like the outpatient setting or inpatient, like
No, inpatient. So the inpatient going into the outpatient, that you guys do the
yeah,
we use Epic at our
yeah,
system.
Epic too, yeah.
So when you do the after the consolidation of medrec at the end, and then the ABS is formed, and that's the medications they're going home with, I always find there's something missing. Whether like the note said continue carvedilol, and there's no carvedilol in the after visit summary. Patient's going home without it. It's like, what the heck? The note said
No,
it.
I think that does happen frequently. And I think, have you heard of like the Swiss cheese model?
Yes,
For like
yes,
preventing,
yes.
so I think pharmacists are part of that like Swiss cheese, right? Like
Yeah.
first line is like the physician doing the best that they can with the time constraints that they have to do like a proper discharge medrec, where they're like looking at the notes. Of course, some things get missed, right? And then the next thing, maybe it's the pharmacist who's like double fact checking, and then they reach out to the physician, and be like, "Hey, you said Coreg 12.5, but you didn't order it, right?" And then it's also important that the physician do an admission medrec, right? 'Cause maybe they had Coreg at home and it's not needed. So I think pharmacists, I think there's a lot of room for error in the discharge medrec and the discharge process, and you need a lot of like cheeses to catch errors that may pass through.
It's funny. I said carvedilol, you said Coreg, and I tell this to pharmacy students all the time. I'm like, physicians speak brand, do not speak
All right,
generic.
Coretta.
Physician, Physicians speak brand. You
It
just
saved me.
gotta learn your.
It saved me an extra syllable. That's why I said it.
Yeah, that's true. That's true. No, it's true though. But the brand is always mostly used. What has been your most viral post, and why do you think it resonated with so many people?
Hmm. I think right. Yeah, my most viral post.
Or
I
I
think I
guess
wrote one.
if you don't know the exactly viral one, I guess the one that had the most like feedback from it or
Yeah, I
whatever.
think the ones that continue to bring in like a lot of subscribers is my post on Humira. I think the most successful drug to ever hit the market. Um, I wrote about that, I think in January of 2023. Yeah. And it just, people ate it up just because it's just like shows the issues with patent protection, issues with innovation, finding a balance. So that one did very well. Honestly, this all has to do with drugs. Cost plus drugs also did extremely well. I think Mark Cuban actually like shared the article on LinkedIn and with the company. So actually, I guess the posts that are doing very well right now are the ones
Are
that
pharmacy related.
are pharmacy related. But I guess because it's so relatable, because you don't need to be a physician to like capture the essence of the issue. You a patient as well, so it's kind of like consumer news as well.
Looking ahead 10 years from now, or before we even go to that, do you remember your first post that you ever made on
Uh,
LinkedIn?
do I remember my first post on LinkedIn?
Yeah.
What year was it?
I
Do you
know.
do you?
To be honest, I didn't scroll back. You posted a lot. I didn't scroll back all the way. I
I
was just
thought you.
I'm just asking to see if you remember, but I'll definitely go scroll back and message you on what the post is.
Oh no, I thought you went way back.
No, I didn't. No, I should have. But I just came up with the question right now.
No, so I
I
think the first Healthcare Huddle article I wrote was December, I think 22nd, 2019. I wrote something about the ACA, the Affordable Care Act. I wrote something on Fitbit, and I think I wrote something on obesity. It was like the first newsletter I ever sent.
And
Um,
at that point, did you understand copywriting, or you
no,
just had no idea? You just speaking as your thoughts.
I just like broke down. I, early Healthcare Huddle was more of me just like simplifying like complex news, not so much of me offering my own opinion, which is because to be honest, I didn't have the experience yet to really offer an opinion. So at that time, I just like broke down something I read in the news, and then over the next couple of years, definitely in 2023, 2021, we got time flies. It was when I really started to offer my own opinion, um, and stance on issues.
Where did you learn copywriting and what was your
I
first
didn't.
experience with it?
I don't know anything about copywriting. I just wrote.
Come on, man.
Ba-
You structure your post you know what's going on. You know what a hook is. You
okay, so
understand.
I guess for LinkedIn, I posted enough times. I've seen kind of what does well to know that like, the first line needs to be the hook. Um, and then you offer details, and then you do like why this is important, why this matters, big picture, and then I do my CTA, my call to action. For Healthcare Huddle though, I think I read someone gave me like two resources very early on, like how to write. Um, Not just write in general, but like write in a simple way. Um, so someone like told me about like the reverse McKinsey pyramid principle, which you have a pyramid, you flip it, and like you start with the main point, and then after that, you talk about yourself. And so basically, I don't consciously think about this anymore. So I hope I still do this, but like the first sentence of each one of my articles, you should be able to read without reading the rest and still understand the entire article. Um, so that's how I structure. Like I make sure like first sentence is like the main point of what I'm talking about for that paragraph. The rest is just supportive. And you can read further if you want, or you can just read the first sentence and you'll be good.
Do you think the
Um,
news is harder for them to write the newsletter or the LinkedIn posts? I know they might be related sometimes. Sometimes you like debrief what you're writing in the
yeah,
healthcare huddle, but
I would
which
say
one is more challenging?
at this point, probably LinkedIn, because honestly, I don't really like, I'm posting more on LinkedIn, or I'm trying to. And I'm trying to do it as a way, like a top of funnel to get people to join Healthcare Huddle. Healthcare Huddle newsletter, at this point, like I've written 300 plus art. Like I just know how to write. Like it comes so easily now. Um, but then like converting it into LinkedIn, which is like shorter copy, like what are the main points? How do you hook people? It's definitely tougher.
Yeah, I started a newsletter like about 4 months ago, 3 4 months ago, called Pharmacy Unlocked, and it's challenging. And I've heard you talk about how you gather your resources from Twitter and then bring them into notes, and you just put them in. And I actually learned a lot from listening to how you do it. So I'm definitely
Oh,
gonna
nice.
steal some of your ideas on how you gather data, because gathering that information to write is the challenging part, I think, especially
Oh
when
no,
you
of
have
course.
like a job.
Yeah, it's all about like you need to have a good and a like robust like resource process, writing process. Yeah, so like I know I have articles that I know I'm going to write about in like April, and like I'm already like as news pops up, I save them and I won't look at the article until April. But I already did like the preliminary research.
A couple more questions. Looking ahead 10 years from now, how do you envision your role in healthcare evolving? Might be a little loaded question, but I just want to see
Yeah,
your future.
yeah. So 10 years, if I continue practicing medicine and I continue healthcare huddle, I think by the time I'm nearly 40, like I will have a lot of knowledge, a lot of clinical and industry knowledge to really make a dent or some sort of progress in healthcare, whether it's with Healthcare Huddle or something else. Um, my desires to, be part of some sort of larger movement to help change healthcare and like be able to offer my expertise in both clinical and industry domains. And again, if that's with Healthcare Huddle, that's great. If I build Healthcare Huddle into like a powerhouse of like healthcare media company, great. But definitely in 10 years, I will be doing something that's like taking advantage of these areas of expertise I have.
It might be too early for this question, but have you ever thought about an exit of healthcare huddle? Like
Yeah.
if someone was to come acquire it?
Yeah. So like Healthcare Huddle, again, like we got acquired in
Yeah.
uh, November of 2021, and then we got it back in November of 2023. Um, if I reach a point in my training or my, you know, real life, like I have a kid now, I have multiple other kids, and it's just not sustainable Healthcare Huddle. It's not fair for my audience to get like half baked content. And if I find myself hitting that point, I will look for a way out or maybe hire someone else to come in and write. Um, but at this point, like I tell my wife, like if someone wants to acquire me, it needs to be for a lot of money because right now I just love doing it so much and
Yeah.
I'm just having a lot of fun.
That's awesome. Two more. What advice would you give an aspiring medical student, healthcare student, that's early in their career, or an early professional that just maybe just graduated this the past summer?
Yeah, I guess my main recommendation is just I'm not sure if this is like I don't know, people say this all the time, but like be non-traditional, right? Like I think healthcare is so there's so many like old school dogma that like you need to do research, you need to do this. Listen, I got into residency and all I did, I didn't do anything research wise in medical school. I published like QI projects, which is like kind of like innovative, but I just did Healthcare Huddle. That was my um stand, like that was my like MO. Um and to like find something that you truly enjoy and just like be passionate about it, that's like going to be your key to success. Doing stuff, you're hitting a point where your time it will start getting valuable, and people will start like wanting your attention, and you just need to be able to like find a path, stick with it, and like block out everything else. So like being able to say no to things, uh, being able to like look at your resume and like make sure it's telling a story, right? Like if you look at my resume, you'll see that I'm obviously interested in like systems change. I'm interested in like entrepreneurship, like innovation, and like that's a story I tell. Quality improvement. So it's very like system related, and that's like the story I'm trying to make as I progress through my career. So you don't want to be all over the place. You want to have like a defined path. It's hard to find that, but you just have to explore, network, talk with a bunch of people.
Yeah, I think that's so perfectly put, and I could double down on that for anyone that's a pharma school, like the non-traditional route. Like I started podcasting in 2018, and throughout my pharmacy school years, and when I came up to my residency interviews, like the podcast was like the number one topic in every interview. And they're like, how did you interview this person? How did you do this and that? Like it was such a big thing to them. And I guess back then podcasts weren't as they are now in 2018, but it's still to this day, I think if you do a simple thing as not simple, but starting a newsletter, it might be easier than start a company, like a like a company with a store, or starting a podcast. These are things that you could just start. We spoke about it earlier. Like you could just use your phone
The
to
iPhone.
have use as a camera and start your journey. It's about just being non-traditional. I think that's great advice for someone right now. Jared, if I was to go back to undergrad, medical school, speak to your best buddy and speak to your favorite teacher, and I asked them, "Hey, who was Jared?" What would they say?
Um, I think someone who's like down to earth, passionate, um, and maybe a nerd.
Okay, okay.
I think those
Sounds
three.
good. All right, well, I'm gonna leave you the last words. I appreciate you for taking the time to sit down with me. I really enjoyed the conversation. I think we need more of like the pharmacist physician like interactions. I think there's such a divide in like the LinkedIn world of people just like coming at each other, and I feel like us working together can just bring so much better for the outcomes of healthcare and the patients. So I appreciate you taking the time, and I'll leave the last words to you.
No, I agree. Thank you for having me. This is a great discussion, and um, yeah, I am in agreement that we need better relationships between physicians and pharmacists. And I've been tapping into my pharmacist, and I think patient care has all around improved because of it.
Awesome. And if you haven't subscribed to Healthcare Huddle, definitely go ahead and subscribe. Follow Jared on LinkedIn. And I appreciate everyone that tuned in. My name is Nima, Jared Dashevsky. Thank you so much.